Hi guys, today we're going to talk about disc pain. I'm joined by our clinical lead physiotherapist Khalid Khan and our senior physiotherapist Adrian Kinkle. So we're just going to talk about some of the topics of signs and symptoms, misconceptions, when to refer when someone's got disc pathology, or the difference between a bulge, prolapse or herniation. Just a bit of background about disc pain. Disc pain is a very common lower back pain. 50% of people will experience lower back pain within their lifetime. 25% of people will experience lower back pain within a year. So guys, disc pain. Carl, what would you say disc pain is? When you speak to your patients, what do you explain to them what disc pain is?
In general, disc pain, okay, well, I mean, that's a big topic there, man. Let's talk about the anatomy first of all when we kind of talk about disc pain. So what is the disc itself? It's this little cartilage ring that sits in between the bony segments of the spine, okay? And inside that ring is a little jelly-like substance, and that jelly-like substance tends to kind of sometimes get squished and gets pushed towards the edges of that ring. Sometimes it can kind of press against it and cause a bulging disc, and sometimes it can actually completely come out and cause a herniation, and that can sometimes upset the kind of balance in the back, basically.
You know, when we get referrals from consultants, consultants either say on the MRI scan or the report, they say there's a disc bulge or a disc prolapse or a disc herniation. Patients get a little bit worried about the terminology of each three of these. What was the difference between a bulge, a prolapse and a herniation?
Well, generally with regards to a bulge, like I said previously, the jelly has started to move towards the outside, and then you can see a little bulge kind of form on the outside of the disc. And again, a prolapse is a kind of an extenuation to that, and then a herniation is where it's fully come out of the ring, causing this kind of little red type thing here, where classically where you get that kind of sciatic nerve kind of trap, if that makes sense. But then also sometimes we can get what we call disc degeneration. So what you see with our older clients is that the disc itself has narrowed just because of general wear and tear.
Fine. Adrian, what do you tell your patients when, what type of signs and symptoms is there when someone's got a discogenic pathology?
So people that normally come into our clinics with disc pains, we see them have preferential movement patterns where they're trying to kind of keep, usually they've got one side that they're more comfortable to moving into, because the other side tends to be painful, or if they move towards the painful side, it causes their referred symptoms, as Carl said before. They'll tend to protect the area. They'll feel generally stiff. They'll feel worse with inactivity, and they generally feel a bit better with getting moving and keeping moving.
Sometimes, again, you can get like kind of gradual symptoms that come on over time, and this could be just general from daily habits or work life situations. And then sometimes you get the classic kind of picking the old heavy bucket up, and then you feel something in your back, and a couple of days later you might feel a little bit of leg pain or something along those lines. So sometimes, a lot of the time with regards to disc pains, they can be a little bit, misleading. Okay, so sometimes it could be just a muscle spasm or something like that gets kind of misdiagnosed as a back pain. So
Because most people, they come in, they normally ask, is this a mechanical lower back pain or is this disc pain? How do you guys normally distinguish between whether it's mechanical or if it's actual true disc pathology?
Well, that's the $1 million question. Generally, you could look at like time frames. So if it was, say, a fresh disc injury, then you would look at, say, for example, if it was quite a sudden onset, and if they had some leg pain or sciatic symptoms, you may be thinking maybe towards the kind of disc pathology. Regarding mechanical pain, if you were just generally getting quite localized pain after periods of, say, long sitting or long standing or walking, then you could kind of go towards a more mechanical type nature.
What about you, Adrian?
So I would kind of argue that when you look at those types of movements, almost that all disc pains tend to have a mechanical element, whereas not all mechanical symptoms around the back have to be a disc problem.
Which is very true, which brings us on to our misconceptions, I feel.
Yeah, there's a lot of misconceptions with disc pain as well, because a lot of time, obviously, when people get MRI scans, it shows a disc, a bulging disc or a herniation disc, etc. But they don't really have those true symptoms. So what's the main misconceptions with disc pain?
Well, I mean, like if you look at kind of studies, it tends to show that if we scanned a population of 100 people over the age of 25, I think with no pain, and we scan them, we would probably see somewhere around 78 to 80 of them would show some sort of disc pathology, and that's with no pain. So sometimes an MRI can be poorly diagnostical because it's not telling you the true kind of what's going on.
You know, funny that I play football with someone, yeah. He's had an MRI scan. It shows him he's got 3 bulging discs, L3, L4, L5, but he's asymptomatic, no symptoms at all. So I think, you know, when someone has it could just be a mechanical lower back pain or just general wear and tear lower back pain, they go get an MRI scan done, and the MRI scan shows that it's got 3 level bulging discs. They get quite worried about this. So that's a classic misconception that I normally see in practice. But when do you know when to refer on to for an MRI scan, or when do you know when, okay, fine, physiotherapy is not going to help, this needs an alternative route, invasive treatment such as an injection or anything like that? Adrian?
I mean, as a general rule of thumb, when we spoke about disc pains initially, we want to try and keep them moving, and so we trial a round of physiotherapy for a couple of weeks or 3-4 weeks, and if symptoms aren't improving, then you can consider going down the route of investigations to make sure that there isn't anything else or anything more serious in the area that causes the symptoms. If there's any referred symptoms, like Carl said before, about kind of nerves and any significant pains going down the legs or starting to affect your day-to-day activities, including sleep, then you can consider a bit of a referral initially.
Generally, when you get that kind of sciatic symptom and you're getting lots of weakness down the leg and lots of pain, and it's very hard to kind of go away or kind of even reduce, then a referral is probably appropriate if it's really affecting someone's lifestyle. However, if we look at kind of studies these days of MRI scans where someone's kind of freshly herniated their discs and it's got quite a big protrusion, and then 9 months later they scan the person again with no operation, there tends to be a reduction because the body will naturally try and heal that area. It's just like anything. If you get an injury to something, your body will naturally heal it. So as physios, chiros and osteos, what we have to aim to do is get the person back to their daily things as the body tries to repair itself.
So obviously there's various types of treatment options that we can use for disc pain. What type of treatment options are there availability for physios, chiropractors, osteopathy users, and then what type of options are there available if it's more of an onward referral from a consultant space?
First line of treatment would be conservative management, which involves us as physiotherapists or the chiros or the osteos, as you mentioned. And it would start off from the very early stages where we try and manage the pain first. And that can be done through a few different options. Initially, we try and do some light, comfortable movements away into that preferential direction, as we kind of spoke about initially. And you can use some pain modalities such as ultrasound and electrotherapy and acupuncture to help ease off some muscle tension, relax some of the muscles around the area, or desensitize some of the muscles that have tightened up as a result of the disc symptoms.
I mean, like going on, let's say, yeah, that was pretty well said there, Adrian. From the acute stage, I couldn't think of much else I would probably do. I think maybe moving on towards the kind of mid-term and the long-term, I would probably start focusing on kind of loading the back more, so to kind of bring it over to their more daily lifestyles if they're having to pick things up from the floor a lot. So we're going to give them exercises, getting them into those kind of positions, or if they're struggling with gardening. So we may do some exercises that kind of simulate those kind of things so their back is stronger and more durable to those kind of daily tasks, basically. And again, I would still probably, sometimes if I feel it's appropriate, I'd use my hands and the modalities like your acupunctures and electrotherapies to kind of manage the symptoms. But then, yeah, it's just about after a while trying to get the patient kind of getting back into their normal daily lifestyles, really.
What about treatment options when they're referred on to consultants, so onward referrals? What type of treatments are available for patients?
Normally what I find is the moment you refer onto a consultant, the first next step would be getting those investigations done, like we've talked about it initially, just to find out what exactly the issue is around the area. And those investigations usually are done not only just for the diagnostic reason, but to guide that future management. Is it something that they could operate on, or is it something that is not going to recover just conservatively and they have to operate on? Or is this something where the surrounding tissue is just so sensitive that it continues to kind of react to the area to the disc that's happening there, and they can just inject perhaps usually a corticosteroid or mixed with a bit of an anesthetic to manage the pain, which gives us as physios or clinicians that window of opportunity when the pain is a bit more controlled to do a bit of more movement, get them upright, get them moving into, like Carl said, into those functional activities.
Can I use the terminology like when something's inflamed or is trying to heal itself, and if there's too much inflammation, what I say is like an anti-inflammatory, like your ibuprofens, your low-level ones, tend to be like a little water pistol on the area, while the injection's like a big fire hydrant hose, if that makes sense. You know, it's really going to try and calm down that.
That's a good way of putting it, mate.
Exactly. So,
is that what you tell your patients?
I do tell my patients that, yeah. But I tend to find particularly steroid injections are really effective when it comes to like if someone's got a real persisting sciatic nerve pain or general arm pain as well, if it's coming from the kind of nerve root region, so this little region here.
So obviously, unfortunately, if the conservative of the injection therapy doesn't work, then consultants will obviously perform surgery, and obviously we're in that position to hopefully prevent that from happening. So I think that's it. Thanks, Carl. Thanks, Adrian, for your input on your knowledge on disc pathologies. Next video we'll be shooting, me and Carl will be demonstrating exercise that we provide to our patients for people who are suffering from disc pain. So we'll catch you then. Thanks a lot, guys.